Yeah, hello everyone. A warm welcome to all of you in front of your screens around the globe, joining this wonderful UCARE LevelUp session with us. It's the first grand rounds of UCARE LevelUp, so we are very excited about this session, and we are very happy that you are all being here with us. We have a small faculty, which basically consists of myself. Let me introduce myself. My name is Siebenhaar. I'm from Berlin. I'm heading our outpatient clinics here at Charité for allergology, and I'm also involved and affiliated at Fraunhofer Institute on translational medicine and pharmacology section, immunology and allergology. And with me is Zenon Brzoza. He is head of Department of Internal Diseases with divisions of allergology at the University Hospital in Opole, Poland. We have brought two very exciting cases to you, which are presented by two very experienced speakers, Claudio Parisi from Buenos Aires and Andaç Salman from Istanbul, Turkey. But before we come to their cases, let me introduce a little bit what this Level Up Grand Round format is for. So we want to discuss these two cases with you, not only with us as the faculty. So please make this a group discussion. You are all invited to participate in giving your opinions on the cases, your own experience you can share. So we are looking very much forward in having fruitful discussions on these two cases. We need to stay within the 45 minutes, and we will make sure to do so. Before we start, let me also announce that I'm very happy that we have 50 registered participants in these sessions coming from 21 different countries, which is fantastic and which shows how successful and useful these sessions are perceived around the globe. So thank you all for joining this, and all stay tuned. And last but not least, let me also thank the sponsors, all of front, Novartis and Allakos, two companies that are very instrumental in helping us treating our patients with urticaria and making these kind of sessions possible. And with this, Claudio Parisi, let me again introduce you. So you are from Buenos Aires, Argentina. Actually, you are the head of adult pediatric allergy section there, and you're members of a lot of boards and directors. So I think most of you and us know you anyways. So I'm looking very much forward to the case you brought to us. The stage is yours, Claudio.
Thank you. Thank you very much for the presentation. Hello, everybody. It's a great pleasure for me to share this presentation with you. I especially thank the organizers of Level Up UCARE for the invitation. Well, let's start with the presentation. I present a 66-year-old female patient who is a juvenile judge and who was referred by her family physician because of 30-month history of pruritic rash with wheals. She also has a history of obesity with a body mass index of 30, and a diagnosis of autoimmune disorders, including Sjogren disease, Hashimoto thyroiditis, and primary biliary cirrhosis. Due to the rash and the treatment of her autoimmune diseases, she has received multiple doses of systemic corticosteroids, and as a consequence, osteoporosis and fracture of the third lumbar vertebra. She has also great impact in her quality of life. She does not leave her home frequently and has temporarily stopped working. The complete treatment received up to the time of consultation was antihistamines, cetirizine 10 milligrams a day, hydroxyzine 25 milligrams at night, steroids like prednisone 12 milligrams per day, and others medications like deoxycholic acid, omeprazole, thyroxine, magnesium, and clonazepam. The physical examination showed wheals that lasted less than 24 hours in most cases, leaving no residual lesions. They increase in areas of pressure, are mainly pruritic, but sometimes painful. She has sporadic episodes of angioedema of the lips and eyelids. We asked the patient to complete 2 patient-reported measurements, UCT, urticaria control test, UAS7, urticaria activity score. The last was given and then was brought in a week later. A control urticarial test was performed, yielding a score 2, which means uncontrolled urticaria. The result of UAS7 was 42, means severe activity disease. Based on her history of disease, an extended laboratory workup was requested with a complete blood count, autoantibodies, thyroid function, and autologous serum test. As some lesions were painful and lasted more than 24 hours, the dermatologist of the team also performed a skin biopsy. Positive results were found for antinuclear and antithyroid peroxidase antibodies. Immunoglobulin E was within normal values, and the biopsy did not show vasculitis. The autologous serum test could not be performed due to the clinical impossibility to withdraw antihistamines and corticosteroids. Type 2B autoimmunity was suspected as the possible pathophysiological mechanism. Based on Ig within normal values, female sex, poor response to treatment, and other concomitant autoimmune diseases. The dose of antihistamines was adjusted and fexofenadine 480 milligrams per day was started. A new appointment was scheduled in 15 days, but it was necessary to see her earlier due to the lack of response to treatment, with UAS7 of 32 and UCT score of 6 without improvement. Given the treatment failure, severe activity disease, and lack of disease control, it was decided to move to the next step in the treatment, and omalizumab 300 milligram monthly was started. Also, she had an improvement in her scores in subsequent visits. It was not possible to reduce the dose of antihistamines. The dose of corticosteroids could be lower, but she continued to use them intermittently and self-administrated. She returned to work, but with discomfort due to the presence of symptoms. In this setting, the possibility of moving on to the next step in the treatment and starting with low dose of cyclosporine or increasing the dose of omalizumab was considered. The risks and benefits of both treatments were explained to the patient, and it was decided to increase the dose of omalizumab to 450 milligrams monthly. At this point, it is important to remember the patient history of obesity. After 1 month of treatment with this dose, UCT values of 15 and UAS7 of 6 were achieved. 3 months later, the possibility of lowering the dose of omalizumab was evaluated. As we have seen, I have presented a case of difficult treatment of chronic urticaria, possibly due to a type 2B autoimmunity mechanism. And on the other hand, a history of obesity has been described as a possible lack of response to omalizumab. Therefore, increasing the dose of this drug is a possible option. In this case, an adequate response was observed with a high impact in the patient's quality of life. Thank you very much for your attention.
Perfect. Thank you, Claudio. I think you introduced this case perfectly, did all the necessary diagnostic workup, even were able to identify that this patient most likely is a type 2B patient, autoimmune, which is a subtype which we know that it could even take a bit longer for the patients to respond to omalizumab, or they need higher doses, as you also very nicely illustrated here. I wonder on your last slide, you said after 3 months, so she nicely responded then to the 450 milligram dose of omalizumab every 4 weeks. After 3 months, you said considering to lower the dose again. So either I missed it, or you didn't tell us how that worked. So did you were able to reduce the dose, and was she then stable, or you needed to keep her on a higher dose for a longer time?
Yes, we are thinking about it with the patient, because the quality of life of the patient now is very good. The patient don't want to return to the previous situation. And then for me, it's an open question. When is the better time to reduce the dose of omalizumab, and in which way to do it? And then habitually we talk with the patient and explain the possibility, and explain to the possibility to reintroduce the omalizumab if we can reduce the dose. But what do you think about it?
Yeah, Claudio, this is an unsolved question, right? I mean, we really lacking much data. I think we all have experiences, of course, because we treat a lot of patients with omalizumab, and we know that omalizumab is rather a very effective symptomatic than a disease-modifying drug, which is fair enough. But your question is well taken. What is the best time to either tapering down or to stop even the treatment, and how we do this? I think we not yet have the perfect answer to this, right? We do it the same way you do. You know, we discuss with the patient. I mean, there's different personalities. Some patients are very anxious, even if they had like urticaria for many years, and as you know, impactful like your patient, you may even love to let them on drug, you know, to let them enjoy that they don't have urticaria. You know, I think this should be even you know, kind of a joint experience making within the UCARE networks. Somehow we need to bring this together. If 3 months is okay, or is it too early? Should we, you know, it's hard to say. I think it also depends, you know, on the availability of the drug. You know, I know that we know that in some countries you even have to reconsider, stop the treatment after 3 months. In other countries, we know we can just continue. But I think somewhere between 3 and 6 months of complete response, as you nicely showed, even viewing the PROs, UCT of 15, complete control disease, which is perfect. And then, like, I think after 3 to 6 months, it is good to taper down, especially if you have a higher dose. You want to make sure if it's not possible to reduce to the standard dose at least, and how to do this. You know, I think we would rather start and like prolong the intervals, probably, not giving the next dose after 4 weeks, just wait for 5 weeks, wait for 6 weeks. And I think by pharmacokinetic thinking kind of reasons, I think if you manage to come to 8 weeks without reoccurrence of symptoms, you could be quite sure that you actually can stop the treatment, and spontaneous remission, if it was influenced by OMAR or not, we don't know, but will probably be stable, right? We have, I think, some questions also from the audience in the chat. Let me check here. So Ibrahim asks if a skin biopsy is required if the symptoms and lesions are going. Okay, wait a minute. Is skin biopsy required if the symptoms and lesions are going with chronic urticaria? Not sure if I understand the question right, Ibrahim. I think the question, I understand it, is, do we always need to take a skin biopsy when we believe it's chronic urticaria? Or is there some reasons or special situations in which we should consider a skin biopsy? Claudio, you want to answer that?
Yes. This biopsy is not an habitual diagnostic test for chronic urticaria, but this patient particularly have some lesions, painful lesions that with the duration more than 24 hours, not all, but with the background of autoimmunity, we try to check the presence of differential diagnosis like urticaria vasculitis. This was the question that we talked with the team and decided to do the biopsy in this case in particular.
Yeah, totally agree with you, Ibrahim. So the reason of skin biopsy is to exclude urticaria vasculitis, actually. Yeah. And I totally agree. So our alarm signs clinically is you have very long lasting or very painful lesions or any other signs, even from the lab, that may you thinking into the direction of urticaria vasculitis. I think taking a skin biopsy never is a mistake. If you are not sure, especially in patients that do not easily respond to treatment. Yeah, so you want to make sure that you don't oversee urticaria vasculitis or even any other autoinflammatory disease that are all rare, but that could be coped by same looking lesions. So Salman, we also answered your question, I think, because it was on the same topic. And I like the next one, which is from Alker. He said, you know, since we have these patients in which it may take a while for the OMAR to work, should we not consider to have like kind of a bridging treatment in the type 2B patient especially to cope the onset of omalizumab, what we expect only to happen after 3 or 4 months of treatment? And should we consider continuing intermittent steroids, or should we even introduce cyclosporin as a bridging treatment? So Claudio, what's your take on this?
Okay.
It's a difficult one.
Yeah. In the decision to treat with omalizumab or not with cyclosporin, we think about the adverse effects and the background of the patient. We try to use the more safety treatment for this patient. And talking with the patient, the option of omalizumab was the better option for her. And we have some problems in Argentina about economic barriers. It's more easy to indicate cyclosporin, but I think that the best option was this kind of treatment. I don't know if it's okay, my answer, if I understood okay.
Yeah, absolutely. I think this is a topic which we haven't yet well addressed in the guideline, yeah, right? Because I mean, we want to bring the patients on an effective treatment as quick as possible. But I think the question is well taken, right? Even if we identify a patient as being, you know, mostly on the type 2B side, and we expect OMAR that it will take some or several weeks really to become effective. What are we doing? Yeah. And I think because the question is also what would be preferred, I think it really depends on the patient, right? If you have like frequent episodes of angioedema, yeah, maybe you need some steroids in between. We would never rate for like a continuous treatment of steroids, but whether or not cyclosporin should be introduced to cope the time until the OMA works, I think needs to be an individual decision. Yeah. It's not an easy one to answer, but it's a very well taken. Yeah. Also, there's a second question on OMA. So what would you prefer or what would we prefer in these patients in which we need to change the OMA dose? Would we prefer to increase the dose or to shorten the intervals?
Well, again, we have to talk with the patient, and the two options I think are good, but we try to use monthly, maybe to the patient go to the hospital to the application. Then I prefer monthly, but the possibility to use short intervals is another possibility to evaluate.
Yeah, true. Both is possible and both is recommended by the guideline. I can tell you how we do this, because to our experience, there is even two types of patients. There's some patients that respond quite nice to the OMA dose, but it doesn't last for the entire 4 weeks of interval. But they may be controlled for 2 or 3 weeks after they got the injection. And then there's others that never reach kind of complete control with the 300 milligrams of OMA. And I think this can be very well captured and having the patients doing the UAS7 over the time of introducing OMA. And we actually adjust to this. So in the latter one, where there is never complete response, but partial response to OMA, we would rather increase the dose. And in those who have a complete response, which doesn't last for 4 weeks, we would rather try to shrink the intervals and keep the patient on this complete response. Maybe this could be a guidance, because I think both is okay, both is recommended. Both are like kind of true and helpful, but this could be the guidance how to decide whether to increase the dose or the frequency. I must say sometimes it's a bit easier to shorten the intervals than coming to increase the dose. Here in Germany, I can say we also need to discuss with the healthcare providers and ask for reimbursement to increase the dose. So usually we also need to do this with the intervals, but it's not so obvious then sometimes. But I mean, okay, not saying this openly. Daniel has a question, and he asks for is CSU inducible in any animal models? And if so, which stimulus can be applied? It's a difficult one. I can go ahead and say, Daniel, I've never heard about a good model of CSU in animals, at least not in mice. I don't know. I have seen like horses and dogs and even cats having urticaria. Usually not the guys we use for experiments. But I think there's not an easy animal model to use in urticaria. And if the question is directed, if horses or dogs have the same reason why they get urticaria as in humans, I must say I don't know. But I open up the question to the faculty if you have any other information on that.
No, unfortunately not.
Yeah. All right. Okay. I think there's no more questions in the chat. Then thank you, Claudio, for this brilliant case and a wonderful presentation. And thanks the audience for these questions. Please stay tuned because we now come to the second presentation, and I hand over to you, Zenon.
Thank you very much, Frank. It was very nice to listen to your discussion, especially these aspects that are connected with changing in omalizumab dosing. I think this is a great challenge just to try to assess what is better, to shorten the interval or to increase the dosage. And I completely agree with what Frank has said, that there are different types of patients. Sometimes we can see that it's better to shorten the interval, and sometimes we see that the interval is not a problem. The problem is the dose. Mm-hmm. So we should check it. It depends on the patient. And thank you very much, Claudio, for your presentation. It was very nice, and it was interesting aspect in your presentation connected with obesity. I think this aspect will repeat once again in our second presentation, and it's my pleasure to introduce Professor Andaç Salman from Istanbul, who will present us another case of patient. Andaç, the audience is yours.
Thank you, Zenon, for the introduction. You can all see the presentation. And I also would like to thank the UCARE LevelUp for bringing us together. And I would also like to thank the audience for joining us this evening or morning, midday, wherever you are. And our second patient of this grand rounds is a 51-year-old male. And his past medical history included he was an ex-smoker. He had a history of coronary artery disease for which he had coronary artery bypass graft surgery. He did not have any atopy. And once again, this patient was also obese. He had a body mass index over 40, which indicates class 3 obesity in our patient. He was on treatment for the other medical conditions, including atorvastatin and diltiazem and acetyl salicylic acid. And his chief complaints was the presence of urticaria and angioedema for the last 3 months. He was treated with oral antihistamines and several courses of oral corticosteroids and montelukast. And he showed some partial response to oral corticosteroids, but he did not show any response to oral antihistamines and montelukast. When we examined the triggers, he claimed that he had some episodes of urticaria with some antibiotics. And although he defined some provocation of the lesions upon pressure, we did a provocation test and we did not see any positive results with the provocation test. And his daughter had also chronic urticaria. And other than that, he did not have any family history. And we ordered the laboratory tests and upon the diagnosis of chronic spontaneous urticaria, and we checked the complete blood count and the acute phase reactants, the total IgE levels, and they all turned out to be normal. And just he had a bit of high levels of D-dimer at the initial presentation. So his initial visit was in October 2017. He was on treatment with desloratadine, 20 milligrams per day, montelukast, 10 milligrams per day. And in addition to those, he also had several courses of IV antihistamines and corticosteroids on an as-needed basis. And the patient-reported outcomes showed that he had a moderate severe chronic urticaria based on the UAS-7 score, and his urticaria was pretty uncontrolled, which is indicated by a UCT score of 7. So we planned a treatment for the patient. In addition to high dose of standard, high dose of H1 antihistamines, we tried to start with omalizumab, 300 milligrams per 4 weeks. And we started with that treatment. And during the first 3 doses of omalizumab, we barely had some effects. We just had a small slight decrease in the US7 score, and we didn't see any change in the UCT score. And he still had to have some IV antihistamines and corticosteroids during those 3 months. So at that time, we did not have the opportunity to omalizumab updosing, and also the immunosuppressive treatments the patient did not want to use at that time. And we also consulted to his cardiologist, and they switched the ASA to another anticoagulant agent. And so we decided to add colchicine, 2 milligrams per day, although it's a bit early to see the full effect of omalizumab. Because we did not see an effect, we plan to add colchicine, which we are very familiar because of the Behçet disease. And after the addition of the colchicine and the continuation of the omalizumab and desloratadine, we still did not see any good effect, any good response. And after the 5th dose of omalizumab, we had to make a new plan for the patients. And we plan to add the dapsone treatment, and because the patient has an elevated levels of AST and ALT, we had to decrease the colchicine dose to 1 milligrams per day. And also the patient started a diet and exercise in order to lose some weight. So after this combination, we had a pretty good response, although it's not the full control of the symptoms. And after adding the dapsone and after decreasing the dose of the colchicine, we saw a steady improvement of the symptoms of the patient. And at the end of the 8th dose of omalizumab and the combination, we finally had some improvement in the UCT score and US score, but it was only a partial response. So we tend to continue because the patients had decreased the needs for the IV antihistamines and corticosteroids, and he was still happy compared to the initial presentation. And with the continuation of the combination and omalizumab, and also with the weight loss of the patient, we finally had the urticaria symptoms under control at the after the 9th dose of the omalizumab. Then we stopped the colchicine first, and the patient was still under control. And then we tried to decrease the dapsone dose to 50 milligrams per day, and the symptoms were still under control, and the patient lost a lot of weight, and he was just overweight at the time of these scores of UCT and US7. And we decided to discontinue the dapsone. We decided to decrease the omalizumab. We decided to decrease the dose of desloratadine, and we tried to extend the omalizumab intervals to 6 weeks. With this treatment, he was still under control, and we further decreased the dose of desloratadine to 5 milligrams per day, and we tried to extend the omalizumab intervals more and to 8 weeks. And with just omalizumab administered every 8 weeks, he was still under control, and we decided to discontinue omalizumab as well. And his quality of life was measured with DLQI, and it was unaffected at the time of the omalizumab discontinuation. And the patient was followed up for an interval between 3 months and 12 months, and he did not have any recurrences, and he is still under control until now. And that was the case that I wanted to present. Maybe we can discuss the impact of obesity on disease course, or the impact of the weight loss. And we can also discuss the treatment alternatives when omalizumab or omalizumab updosing is not an option, and it can be in some settings. And I would like to thank you at the end of my presentation.
Thank you very much, Andaç. Thank you very much for your very interesting presentation of the patient that we can meet every day, and it's your patient is very interesting because he has got some comorbidities, and maybe the comorbidities are the cause of severe course of his urticaria. And as I told, there are some common points between both presentations. We have obese patients. What is your opinion? Is it possible that obesity impacts the course of urticaria? Do you have any data on this problem?
I don't have any data, but my observation and the data coming from the omalizumab updosing studies or case series. In some series, it's shown that the obese patients might need a higher dose of omalizumab to obtain disease control. And we also know from the other inflammatory disorders that obesity can increase the inflammation. And we also know that inflammation to some point takes part in the pathogenesis of urticaria. And this could be the reason for a more severe and more resistant course in patients with obesity and CSU.
Yes, of course. Yes, that's correct. I think that in general we suffer from the lack of studies analyzing potential switch between potential connection between urticaria and metabolic problems and obesity and so on and so on. There are only some studies on this. We have performed one of these studies, and we noticed that obese patients in generally suffer from more severe course of urticaria, and probably we suppose it is connected with inflammation. Now we know that obesity is a disorder, and this disorder is connected with inflammation. So maybe, and as you pointed, your patient, because of cardiac problems, tried to decrease his weight, and maybe that was one of the aspects that affected in effectiveness of your treatment. Another problem, from my point of view, connected with this, that because of cardiac problems, he used to use aspirin.
Yes.
Aspirin, as we know, aspirin potentially can decrease the course of urticaria, and in my opinion, there is one more aspect connected with this. The patient changed his diet just to achieve loss of his weight, and maybe his diet was better. He eliminated some pseudo allergens. And maybe that was another point why his disorder improved. I'd like to point our thinking about urticaria on some non-pharmacological aspects of this disorder, and maybe obesity is one of them. And of course, we should always remember about other drugs used by the patient. Some of them can make this disorder worse. What is my another comment? His daughter suffered from urticaria.
Yeah.
Do you think this disorder can be family related?
Urticaria is quite common, and I don't think that it's a kind of hereditary disease, but I don't know, maybe at some point it can be, there might be a familial tendency to develop chronic urticaria, but to my knowledge, I'm not aware of any proven and link between the family history and the urticaria.
And what is your opinion? You know this patient. Where is the cause of effectiveness of your therapy? Because you gave some time to omalizumab, or maybe you added some other drugs. What is your opinion? How do you think?
Yeah, I think it's very difficult. It's very hard to promote any of the factors, and because we waited for omalizumab at least 5 months, and during that time we switched his aspirin to another drug, and he already started to lose some weight. He already improved his diet, and he already had some improvements with omalizumab, although just a partial response. And we also added colchicine and dapsone, and I think all contributed to some point. But in my opinion, I think the lifestyle changes in those patients could be the most prominent one that contribute to remission of disease, because probably he had low levels of emotional stress with the diet, with the exercise, and with the decrease of the episodes of urticaria. And I think the patient himself did a lot for the remission.
Yes, of course, and I totally agree. I think that more aspects influence the course of the disorder. Not only drugs, maybe diet, maybe the loss of obesity, and so on and so on. And my last question is: I noticed when you had success with your therapy, you increased the periods between omalizumab dosages, and you started to decrease the dosage of antihistamines. And let's discuss it. What is your experience? Do you always, when you have success with omalizumab, you still continue the therapy with omalizumab and simultaneously you start to decrease the dosage of antihistamines? What is your experience, and maybe what is the experience from other centers?
Yeah, we usually start the omalizumab as an add-on treatment, as indicated in the guidelines, but sometimes we do decrease the dosage of antihistamines once we get the full symptom control. Yeah. And sometimes in fast responders to omalizumab, the patients themselves just quit using the antihistamines. We had the data about this in a study we did with Ana Jimenez Arnau, and we checked that the use of antihistamines simultaneously with the omalizumab, and some of the patients just stopped the antihistamines as they just started omalizumab, and the others continued omalizumab until full symptom control, and the effectiveness was not very different. But I think this is another point that we need further study.
For the next studies. Thank you very much, Andaç. It was very interesting case presentation. It was very nice to discuss with you these complex problems of these patients. And we have some questions from the audience, and if possible, I will read it. The first question: some results show that NAFLD, fatty liver disease, especially in those with higher BMI, are associated with itch. Can you draw a link between fatty liver disease and activation of mast cells? Andaç, do you have? Could you please try to answer this question?
I wish I could, but right now I can't. But if you can, I would like to hear.
Of course, we know that some liver disease can result in itch. Personally, I do not know any connection between liver impaired function and mast cells, but I think we must check it. Maybe there is a connection. I don't know. So I think we can leave this question open. Maybe somebody else has anything to add. If no, let's go to another question. Great presentation. What is your experience with colchicine in treatment of refractory urticaria, and in which patients do you prefer to use it? Andaç?
Yeah, we used to use colchicine a lot in the pre-omalizumab era, and we usually chose colchicine for the patients with some autoimmune features because it has some immunomodulatory effects. And as we have lots of experience in Behçet disease, we use a lot colchicine, and we find it's a very effective and safe treatment. But we didn't check the results in a systemic way, and so it's difficult to say that colchicine is effective, and we need more data as well in that point, I guess.
Okay, of course. Thank you very much. And the last question, thank you, Dr. Andaç. Why you choose Dapsone, not hydroxychloroquine?
There was no reason. It was just because we sometimes use colchicine and Dapsone combination, and we also sometimes use hydroxychloroquine. And I think it can be used also in CSU where the omalizumab is not an option. And also we had, I just saw a very recent study that was published in Journal of Allergy and Clinical Immunology. That was a large case series of patients using hydroxychloroquine and omalizumab. And hydroxychloroquine was also effective up to 60%, if I'm not remembering wrong.
Yes, of course. Thank you very much, Andaç, and it was very nice. And let me summarize. Maybe we should think about the study on big data, analyzing connection between urticaria and obesity and metabolic problems. Maybe that's the idea for the next between UCARE center study. Frank, what is your opinion?
Yeah, I totally agree. And I just wanted to add to this. I think there's not a lot, but in the back of my mind, there's something I have read that maybe even short chain unsaturated fatty acids may also influence not inflammation only, but also have a direct impact on mast cell activation. So, but I think it's totally agree. We need to collect more data on this. Is it the obesity itself, or is it the diet of the patient, which in the end could, not lead as an allergen or direct mast cell activator, but maybe as a modulator, lowering the threshold, making mast cells more reactive, more angry. I think we really need to learn more on this. I very much liked your case, Andaç. This is a great example.
Yes, of course. And I'd like to add something else. In our study, we tried to analyze adipokines, hormones that are revealed by obese tissue, and we noticed some connections. And I think that there is something that we should explore in the future from this area. Thank you very much once again.
Perfect. Thank you all. And we are already on top of the hour, but perfect in time. So, Zenon, I think we have to close the sessions. Do you want to say some final words?
My final words. It was very interesting to moderate this session with you, Frank. So thank you very much. And it was a great pleasure for me to hear both presentations. It was very interesting, and I think we tried to point at some aspects of urticaria that are not so commonly discussed. And thank you very much, the audience, for your interesting questions. It improved our discussion, and I think it brought some new light on this problem. So I think it was very fruitful and very nice to meet you and to discuss this fascinating disease that is urticaria.
I couldn't have said this better, Zenon. It also was a big pleasure for me. Also from my side, thank you to you, Andaç and Claudio. Again, thank you for all on screens. Thank you for your questions. It was just fantastic to have this kind of exchange. And please don't miss the next Level Up session. Thank you all for joining.
Thank you very much.
Thank you so much.
Thank you.
Thanks.